Hello, this is Marilyn, and we're actually at the last model associated with the transcultural caring dynamics in nursing and healthcare theory. And this particular model has to do with actually what I have called transcultural nursing competencies, looking at how do we assume accountability for our actions as transcultural nurses, and then looking at our professional responsibility. So I've got 4 dimensions to this model that facilitates our understanding of how we really come to some level of understanding, agreement, or compromise in terms of our relationships with people who are of different diversities than we are. So the first one, the phase 1, and I've talked about this a little bit, whereas we have a body of knowledge. So many times we think, well, we should be at like a total co-equal relationship with our patients. But our patients do see us as different. They see us as having a body of knowledge. So we have to recognize that unequal power, that we do have power, and we certainly have the power to control pain. And patients in hospitals do see us as having that type of power. So we have to know when and how to use that power correctly and wisely when we are interacting with our patients. And so subsequently within this notion of nursing, we have the authority, the knowledge, we have access to privileged information. We know more about the patient, of course, than the patient knows about us. So that is access to privileged information. And we do have influence. We can influence the health and well-being of our patients. So we need to recognize that, and also look at the way that we communicate, the language we use when we're communicating, and also the customs that are associated with either our professional meaning systems and also our patients. Then the second phase of this interactive model or dynamic model of decision making is the ethic of transcultural caring, which I shared as part of my theoretical model. Again, it's looking at responsibility for the other, mutual responsibility, and then personal accountability, that we must be personally accountable as professional nurses. And because looking at that last model that had to do with conflict, we can see what potential conflicts arise when we're interacting with people and systems that are culturally diverse. So that's the phase 2 of this particular model, and it focuses on ethics of accountability and responsibility. The phase 3 is the ethic of transcultural caring communication, and again, this has to do with ethics. Much of my own research on caring has really come down to understanding the ethical responsibilities that we have in relationship to, again, respecting the patient, respecting the person, and that goes to the people who oftentimes we feel a lot of conflict with, like maybe our chief executive officers or administrators, but really trying to, by virtue of our mutuality, our communication, that we can begin to understand the responsibilities and roles of each other, because each of us in an institution has a different role that we play to help the patient in this patient-centered care to have health and well-being. At the same time, we have to have a healthy institution or it won't function. And so, so within this idea of this respect for person and being mutually responsible. And then the last phase of this ethic of caring is how do we reconcile differences? When we have differences, often we're trying to seek understanding of each other, and sometimes, we may have hopefully not potential conflict, but as a nursing researcher in hospitals, I see an awful lot of conflict that exists. So we have to figure out how we have to work together and how we have to seek this understanding of things that are diverse or different, from the way that we think or we might do something, and how subsequently then we have some level of agreement that can make our workforce healthy, and that's a dominant issue in nursing today, is a healthy workforce, and also our workplace a living organization as opposed to what, for lack of a better word, a dead organization. So, and then at the same time, then how do we compromise? Each of us has our own values, beliefs, and attitudes. So we're working with people of diverse cultures, people whom we work with, our patients whom we serve, physicians also whom we're trying to understand, and our administrators. And so we have to come to some kind of healthy compromise. So the last phase of this decision-making model is to look at seeking understanding, how do we reach some kind of agreement, and then how do we compromise if necessary. And so this model then is a choice-making model, and that's the ultimate endpoint of transcultural healthcare, transcultural caring, which is how do we make the best choices and facilitate the best choices, not only for our patients, but also for ourselves and the physicians whom we work with and the organization that we are a part of. And so I would like to say thank you for your interest in this theoretical model on transcultural caring dynamics in nursing and healthcare. And I feel very strongly about helping people understand the nature of transcultural nursing and specifically transcultural caring in our complex institutions today. Thank you.